Hey guys, our next lecture is going to be over the shoulder. Now these first couple slides, you don't necessarily have to print them, but I highly suggest that you definitely have them downloaded, have like maybe a folder on your computer titled shoulder, and then also maybe another folder of just saying protocols, and so that way it's just easier to download. And also, hopefully when you download them, you'll have the availability to highlight. The other thing too, not alone with your textbooks, but also, you know, with the, you know, with the, Kisner and Colby, couldn't think of that one. And I want you to also follow along with the PTA exam score builders book and look up on a PTA, the rehab center, or even any kind of CPGs, so that way you can get even more detailed information about each of the pathologies. So at the beginning of this lecture, it's just a reminder for you to look over the anatomy and physiology for the shoulder. I'm not going to go into detail, so I'm going to have you do this on your own, but I went ahead and put some information on here as a review, like for convex and concave, and even the muscles that are mentioned in score builders compared to your trail guide to body. So they might be look a little bit out of order, but they should be the same exact muscles. And so I definitely want you to go through those because it's going to talk about the arthrokinematics and motion, and that's going to be really important when we get to lab and associated with joint mobilization. So I'm going to go ahead and keep on going. You can review all of this information like the scapulohumeral rhythm and all of the muscles associated. So they didn't go away. All right, so getting into more non-operative pathologies first. And so we'll get started with that. Let me get my notes here. So that way we're all on the same page. Okay. So, a lot of the very first ones that we're going to really talk about is going to be definitely OA. And, also we'll be talking about some like rheumatoid arthritis, osteoarthritis, traumatic arthritis, and post-immobilization of arthritis and stiff shoulder. And also really common is idiopathic frozen shoulder. So for osteoarthritis, as we already know, but it is a degenerative process and it involves the articular cartilage and therefore results in excessive, from excessive loading of a healthy joint or normal loading of an abnormal joint. So it's usually diagnosed based on x-ray findings, and the prevalence is higher among women than it is men later in life, and that is largely due to because of older than 65 years of age, and they will demonstrate evidence of osteoarthritis. So the most common sites for OA are going to be the fingers, the hips, and spine. And less common is going to include the ankle, wrist, and elbow. So you might be thinking, well, why did we include this in the shoulder lecture? Because you could still have arthritis in the shoulder. But if you think about the ones that are mentioned, those are weight bearing, but besides the fingers. But the hips and knees and spine and the ankle are very, a lot of times more weight, they're weight bearing. But the wrist and elbow are not, but they are more prone to it. So pain from OA is typically described as deep. It's poorly localized, like it's just like, oh, it's kind of all over, or all over my spine. It's not very centered and localized. And oftentimes it's described as being achy, and it is definitely can be exacerbated. The symptoms can be by activity, and it's often relieved by rest. So the areas of the spine that are definitely most susceptible to OA is the lower lumbar and lower cervical regions. And there's typically degeneration of the facet joints, and there's presence of those osteophytes, those little bony fragments that they're just looks like extra bone growth coming off the sides of it. Of the bodies of the vertebrae, a lot of times you'll see that, and even on the facet joints. And And, with OA, you'll have the reduced size of the intervertebral foramen, leading to stenosis. You'll see that a lot of times too. Remember, stenosis is narrowing of, typically the spinal cord canal, but here we're talking about the intervertebral foramen. So if you don't remember where that is, make sure you look where that is, because that's where arteries run through, and it narrows around those arteries. All right, so obesity is a significant risk factor for developing osteoarthritis later in life, and the knee is the joint that is most susceptible to OA because due to obesity, and then after that is going to be the hips and the hands. For OA of the hip, you have femoral acetabular impingement, and this is, with the femoral head and the acetabulum, they may result in OA, and there's two different types of femoral acetabular impingement, to where, either the femoral head can be misshapen, and or it could have there's usually an overgrowth of acetabular rim. If there is OA of the hip, a lot of times they're going to complain of pain in the groin. That is going to be the most common with OA of the hip, and pain in the buttock, knee, and trochanteric region are also consistent with OA but are less common. You also have what's called Bouchard's nodes, and they are found at the proximal interphalangeal joints, at the PIPs, and are that's a common characteristic of OA in the hands. Usually these nodes are often tender in the early stages of OA and can lead to restrictions in range of motion and fine motor skills. The other common nodes is the Heberden's nodes, and that is, with osteophytes in the DIP, and usually are seen in women but not in men, so it's pretty interesting. And a lot of times this characteristic of OA is usually associated with chronic disease, and it causes degeneration of the articular cartilage, primarily in the weight-bearing joints. So like I said, I know that was a lot about all the other joints, but you can see OA in the shoulder as well, but I wanted to go ahead and mention those, and so that way you can carry that information with you as we go along throughout the body. All right, and the rheumatoid arthritis is going to feel very similar to how we just talked about OA, but RA is a systemic autoimmune disorder of the connective tissue. It's characterized by chronic inflammation within the synovial membrane, tendon sheaths, and articular cartilage. Incidence is greater in females than men, and diagnosed more frequently between 30 to 50 years of age. So when they're diagnosing for RA, usually blood work, and through evaluation and looking at the white blood cell count and erythrocyte sedimentation rate, hemoglobin, and hematocrit values. So that's how they're going to determine RA. And the biggest difference, between OA and RA, when you have a patient, maybe they haven't been diagnosed with either one, is just remember, RA is systemic, so it's going to affect more than one joint. So if you have a patient saying, oh gosh, both my knees hurt, both my ankles hurt, both my elbows hurt, whatever that may be, you're probably thinking, you're going to want to start thinking more RA, possibly, compared to osteoarthritis. That's typically asymmetrical, to where it's only going to be on one side of the body, but not always. So, maybe they have severe osteoarthritis in the right knee, and they have mild osteoarthritis of the left knee. So it's definitely possible, and it's pretty common for people to have, say a knee replacement. They're going to have one replaced, and more than likely later on down the road, they usually have the other one replaced too. So, but they kind of, with these different nodes, and especially you can pick up different deformities with RA, especially of the hands, especially if a patient has the swan neck deformity, boutonniere deformity, ulnar deviation of the fingers. But just remember, someone that has RA might also have OA. How complicated can that be, right? So makes them more of a complex patient. So like I said, RA affects women more than men, but the ratio is 3 to 1, and it increases with age, and the peak onset is late 40s and early 50s. Even though most frequently is diagnosed between 30 to 50 years of age. And, they'll have symmetrical and often typically symmetrical, and it involves the joints of the hands, wrist, knees, feet, and ankles typically. And besides outside of blood work, they have to meet 4 out of the 7 criteria to be satisfied for diagnosis of RA to be confirmed. And, usually at the beginning, the onset is typically insidious and usually affects the joints of the hands and feet initially, and then the patient will often report pain, stiffness, and swelling in a variety of joints. So RA affects joints symmetrically, but deformities are typically asymmetrical, which is interesting. So the asymmetry is attributed to this increased use of dominant extremity or protection of a painful extremity. So maybe the right hand dominant, maybe they have more that's asymmetrical deformities like the boutonniere deformity or swan neck deformity, or ulnar deviation of the hands. Oh, I was trying to put my hand in there. There you go. Those would look, that was what it's going to look like, difference for that too. So as far as, there's different phases associated as well with the joint arthritis. So this information is taken from the Pearson and Colby, or not, I want to say Pearson, Kisner and Colby, goodness, Kisner and Colby textbook. And there are different phases that you need to be aware of. So the acute phase, this is when you're going to have pain and protective muscle guarding that's going to limit motion, and it's usually going to be external rotation and abduction in the shoulder. Okay, we're talking about the shoulder. And the pain will frequently radiate distal to the elbow and may disturb sleep. And this will, it's because of the glenohumeral capsule. The joint swelling is, might not be detected during this acute phase, but there's tenderness with palpation in the sulcus, especially at the edges of the Kermian process and between the attachments of the posterior middle deltoid is where you're going to see that. In the subacute glenohumeral joint arthritis, you're going to see more capsular tightness, and that's going to be consistent with that capsular pattern, which, if you remember, is external rotation and abduction are going to be the most limited, and then followed by internal rotation and flexion. So I know some of the textbooks might be a little bit different on how they line that up, but typically you're definitely going to see limitations, external rotation and abduction, and then, maybe flexion and then internal rotation. So, but, this capsular pattern often begins to develop during the subacute phase. So the patient may feel pain at the end of the limited range when reached. So maybe, it's external rotation and they have limitations of range of motion and they have increased pain when they get to that end range or from the limited range. There's also could be passive accessory motion that could reveal limited joint play. So like with the infeels and feeling how much movement does the joint actually feel like it has, it could have a lot of limited joint motion with, like, especially with passive range of motion is pretty much what that means. So the patient can be treated as the acute condition, and if they begin to subside but gradually increase shoulder motion activity, the complications of joint and soft tissue contractures can usually be minimized. So obviously working on, the gradual increasing of shoulder range of motion and also progressing them as they can tolerate with activity. And then that, therefore, is going to help improve with the joint, hopefully, in the subacute phase and even the acute phase, and also help with soft tissue contractures. Now, when you get to the chronic phase, it can look a little bit different. So there's progressive restriction of the glenohumeral joint capsule, and there's definitely signs of limited motion in that capsular pattern that we described, and a decreased joint play. There's significant loss of function with an inability to reach overhead, outward, or behind the back, and pain is often localized to the deltoid region. So, this, especially the chronic phase, can definitely be confused with that adhesive capsulitis. And I think that's, it's definitely very important that your patient does have x-rays as well to see if, they do have arthritis or if it just looks like adhesive capsulitis to differentiate between the two. And now adhesive capsulitis, so frozen shoulder. So I have seen this mentioned definitely in Score Builder's textbook quite a bit. It's one of the gold standards. We're going to look at that one in just a minute too. So make for sure you definitely know all the pathologies I mentioned, but I know that this one is frequently mentioned. OA and RA is definitely always mentioned. But adhesive capsulitis is also known as frozen shoulder, and it results in the loss of range of motion and in that same capsular pattern of limitation, external rotation, abduction, flexion, and internal rotation, or it could be internal rotation and then flexion. So it depends on your textbook. The condition is caused by this adhesive fibrosis. So it's pretty much like scarring, and the scarring that's between the capsule, the rotator cuff, the subacromial bursa, and the deltoid. So patients with adhesive capsulitis will typically demonstrate range of motion restrictions and is consistent with that capsular pattern. There will be inflammation within the joint capsule that causes this fibrous adhesions to form, and the capsule will actually thicken. So stage 1 is characterized by the gradual onset of pain and decreased movement and night pain. The patient typically presents with a loss of external rotation with an intact rotator cuff strength. The duration of this stage is usually less than 3 months, so you definitely need to know the stages associated too. We'll talk about more of the other stages as well here in just a minute. I believe they're in your textbook, but the adhesive capsulitis, now I'm talking on the PowerPoint slide, it'll definitely occur more in the middle-aged population, with females having greater incidence than males. An arthrogram can assist with diagnosis by detecting decreased volume of fluid within the joint capsule. And range of motion restriction is typically, like I said, in that lateral rotation, abduction, and here they mention medial rotation. So see, the other capsular pattern I mentioned, that is from your Colby textbook, and this PowerPoint slide, this information is with Score Builders. So when in doubt, I would just go to Score Builders. So lateral rotation, abduction, and medial rotation, and then flexion, I guess, is followed by after that. So if you want to, you can pause the video for just a moment, and then now I want you to follow along with your Score Builders textbook to talk about adhesive capsulitis. Okay, so I'm going to follow along in Score Builders first, and then we'll talk about all the different stages that's in your Kisner and Colby textbook. So, with adhesive capsulitis, what I haven't mentioned already is, let's see, where did it go? They usually have, because of this thickened capsule, this inflamed capsule, a lot of times they'll have, contractures associated too. And make for sure that you know that they are classified, adhesive capsulitis is classified as either primary or secondary. So primary is spontaneous, and secondary is because of an underlying condition. Let's see, I've already talked about inflammation. The joint capsule causes its fibrous adhesions to form and the capsule to thicken. There's a decrease in space within the capsule that leads to this decrease of synovial fluid and therefore further irritation of glenohumeral joint. So with primary adhesive capsulitis, there's no known etiology. However, a lot of times it is definitely associated with diabetes mellitus, thyroid abnormalities, and cardiopulmonary conditions. Secondary adhesive capsulitis is a result from trauma, immobilization, complex regional pain syndrome, RA, abdominal disorders, and psychogenic disorders. Orthopedic intrinsic disorders can also initiate this process, and that would include the supraspinatus tendinitis, partial tear of the rotator cuff, and bicipital tendinitis. So like I said, adhesive capsulitis occurs more in the middle-aged population, with females having greater incidence than males. Let's see. So also with passive range of motion of the shoulder, is limited during this phase, talking about the beginning phases, due to pain and guarding. And when you get to the chronic phase, pain is usually localized around the lateral brachial region, and the patient is not awakened by pain. Passive range of motion is limited due to capsular stiffness, and pain is present with loss of glenohumeral joint motion, restricted elevation, which just means shoulder flexion, and lateral rotation. So when it talks about for laboratory imaging studies to confirm, an arthrogram can assist with the diagnosis to detect fluid of volume inside the joint capsule. And because the glenohumeral joint usually holds between 16 to 20 mLs of fluid, however, adhesive capsulitis decreases the size of the capsule, so it only holds 5 to 10 milliliters of fluid. And other tests should only be performed for if it's trying to find for differential diagnosis. So what are some information that should be obtained to confirm? Would be the clinical evaluation, if they have a past medical history, if they have the greatest, if the patient presents with greatest restriction of glenohumeral joint motion and abduction and lateral rotation, but all the other planes are usually, but all planes of motion are usually affected. There's usually tightness within the anterior inferior joint capsule. So if you think anterior and inferior joint capsule, and pain with stretching and restriction with passive and active range of motion. So with the history, just like with anyone else, you're going to look at the past medical history, the PTAs, surgical history, medications, but you're going to review all this information, family history, current symptoms, any kind of current health status, occupation, all of those as well. What are some additional findings is you're usually going to see patients have muscle spasms and around the shoulder, and that's just secondary to muscle guarding. And there's usually a loss of reciprocal arm swing that you're going to definitely see in gait training, to where they're not swinging their arms like they should with like a normal sway. And you're also going to see disused muscle atrophy that can occur over time. Let's see. So with management, so with medical management, it's going to definitely vary for the adhesive capsulitis. It is a self-limiting process. It can take over 12 months in its course. So it's really important to highlight and to note, because some physicians be like, well, there's no sense of doing any therapy because it's going to take a year for you to get over it. Pharmacological intervention, and that should, to help control the pain through acetaminophen, or longer acting analgesics or NSAIDs or narcotics. Now, the physician may inject the shoulder with corticosteroids to help assist with recovery of motion, and you'll definitely see that. But obviously, they're definitely not going to give them corticosteroids for someone with diabetes. It's going to increase their sugar. They can also do surgical intervention to break up adhesions or release muscles adhered to the capsule, and that would be a last resort if other conservative management fails. So physical therapy intervention is during the acute phase and includes icing or superficial heat, gentle joint mobilization, progressive strengthening, pendulum exercises, and isometric strengthening. During the chronic phases, the goals could include ultrasound, grade 3 and grade 4 mobilization, increasing the extensibility of the joint capsule, and using techniques such as PNF to restore painless functional range of motion. So for at home, during the acute phase, you can have your patient do some self-stretching, but avoid abduction secondary to the risk of damage to the subacromial tissue, like impingement. So once a patient enters the chronic phase, the program should emphasize self-stretching, progressive exercises, posture management, PNF, and other exercises such as pendulum exercises and wall climbing to assist with improving range of motion. So the outcomes, so with physical therapy, it's usually described for an outpatient basis for 3 to 5 months after diagnosis. Adhesive capsulitis usually follows a non-linear pattern of recovery, and then all of a sudden we'll have a spontaneous recovery that is said to take 12 to 24 months in duration. So what are the long-term effects of the patient's condition? So most patients are able to fully recover over time, but a small percentage of patients experience some permanent loss of motion of the shoulder joint. This loss is frequently asymptomatic and may not impair a patient's functional ability. So what are some, in comparison, distinguishing of similar conditions? So acute bursitis is characterized by pain that is intense and sometimes throbbing over the lateral brachial region. This condition may arise secondary to calcific tendinitis. Active and passive motion in all direction is limited by pain. Abduction greater than 60 degrees of flexion and greater than 90 degrees usually produce severe pain. And acute bursitis lasts for only a few days. And unlike adhesive capsulitis, this condition will usually resolve itself within a few weeks. And I definitely want you to read over these clinical scenarios and be able to apply this information. I know I will have a lot of scenarios in lab, but you can also utilize these as additional. Okay, so that finishes what was mentioned in score builders, and now we're going to talk about on this PowerPoint slide here and back to your Kisner and Colby textbooks about the different stages. Okay, so with idiopathic frozen shoulder, it's definitely called adhesive capsulitis, but it can be called periarthritis, and we've already mentioned what that looks like. Let's see. Move on down. All right, so for stages. Stage 1, I already mentioned, but I'll go ahead and mention it again. It was on the previous slide, but that's a gradual onset of pain, increases with movement, and is present at night. They'll have a loss of external rotation motion and an intact rotator cuff strength is common. Duration of the stage is usually less than 3 months. Stage 2 is often referred to as the freezing stage, and this is characterized persistent and more intense pain even at rest, and motion is limited in all directions. It cannot be fully restored with an intra-articular injection like corticosteroids. This stage is typically between 3 and 9 months after onset. And then when they get to the stage 3 frozen stage, this is characterized by pain only with movement, significant adhesions, and limited glenohumeral motions. Excessive scapulothoracic movement is a typical compensation. They'll definitely have atrophy of the deltoid, rotator cuff, biceps, and triceps brachii muscles can be noted. This stage occurs between 9 and 15 months after onset. In stage 4, they're going to have the thawing stage. This is characterized by minimal pain and no synovitis, but significant capsular restrictions from adhesions. So the motion may gradually improve during this stage. This stage will last between 15 to 24 months after onset, although some patients never regain normal range of motion. So some references will indicate the spontaneous recovery on average of saying for 2 years from onset. So as you can see, it's a little bit different as mentioned in score builders, although others report long-term limitations without spontaneous recovery. And I feel like I've mentioned quite a bit already of, their mobility issues, pain with motion is often even at rest, they'll have acute flare-ups, but with posture, they'll have compensations with a protracted and anteriorly tilted scapula. They'll have rounded shoulders or guarding of the painful shoulder in the position with the scapula elevation and arm adduction. I already mentioned, but they'll have a decreased arm swing during gait. Their muscle performance, general muscle weakness, and poor endurance in the glenohumeral muscles with overuse of the scapular muscles will lead to pain in the trapezius, levator scapula, and posterior cervical muscles. There's usually an increased scapulothoracic motion during arm movements to compensate for that limited glenohumeral mobility. So kind of what it looks like, almost looks like that scapula is really adhered to the glenohumeral or even to the humerus. It's like they just move together. You'll see that compensation occur. So here's some other common activity limitations and participation restrictions. So they'll have the inability to reach overhead, behind their head, out to the side, behind back, leading to difficulty with dressing, like putting on a shirt, putting on a jacket, women fastening their bras, we hear that a lot, even washing their hair, brushing their hair, reaching hand into their back pocket of pants, like maybe to get a wallet out, they'll have a hard time with that. Reaching out a car window, like if you're at a fast food place or the ATM machine, like I mentioned already, but self-grooming, like brushing teeth, brushing your hair, washing your face, washing your hair, and in difficulty with bringing eating utensils to the mouth. They'll have difficulty lifting heavy objects above shoulder level and limited ability to sustain repetitive activities. And for this slide, I'm actually just going to talk about, there's an adhesive capsulitis clinical practice guideline I definitely want you to upload, and it should be on Blackboard. Hopefully it is. If not, you can go through the PTA and find it that way. So some different things, if you want to pause and find that, I highly suggest for you to do so. But I'm going to go ahead and jump into what I have highlighted. So for recommendations, but let's go over the risk factors just to verify. So for the CPG, so you as a PTA, you should be able to recognize if a patient with diabetes mellitus and thyroid disease are at risk of developing adhesive capsulitis, and that adhesive capsulitis is more prevalent in individuals of 40 to 65 years of age, female, and if they've had a previous episode of adhesive capsulitis in the contralateral arm. So that's really important to note because women, especially if you're diabetic, and because if you're between that 40 to 65 years of age, you're more likely to get it in the other arm as well, in the other shoulder, or that's why it says to, especially if they've had it already in the other shoulder. So I'm going to move on down. Definitely look over examination and differential diagnosis, but I'm really going to get into the interventions. So for one of the interventions I mentioned is that corticosteroid injections. So this is strong, based on strong evidence that the intra-articular corticosteroid injections combined with shoulder mobility and stretching exercises are more effective in providing short-term, like 4 to 6 weeks, pain relief and improved function compared to shoulder mobility and stretching exercises alone. So, this combined method is going to be preferred. Another intervention is patient education. And so just describing the natural course of the disease, promote activity modifications is encouraged to encourage to perform functional activities that are pain-free range of motion and that they match the intensity of stretching to the patient's current level of irritability, and that is modern evidence. Another one, this is weak evidence for modalities. Says to use shortwave diathermy, ultrasound, or e-stim combined with mobility and stretching to reduce pain and improve shoulder range of motion patients. So remember, that is weak evidence. There's not enough to support it. Joint mobilization. So this one is also weak evidence that by utilizing joint mobilization procedures primarily detected in glenohumeral joint to reduce pain and increase motion and function in patients with adhesive capsulitis. And the next one is for manipulations, and this is also weak evidence that clinicians can utilize translational manipulation under anesthesia directed to the glenohumeral joint in patients with adhesive capsulitis who are not responding to conservative interventions. And then this one is moderate evidence, and it's important for us to know this one, that you should instruct as a PTA, you should instruct patients with adhesive capsulitis and stretching exercises. So the intensity of exercise should be determined by the patient's tissue irritability level. Well, that's very subjective, right? How are we going to determine the patient's tissue irritability level? Well, just obviously not probably stressing it too much, right? Not trying to increase their pain too much, but just to where they have enough of that for the irritability. Okay, so what did we get from that, right? So from that information is, obviously it's great, strong evidence to combine the corticosteroid injections with shoulder mobility and stretching exercises, and effective in providing for short-term pain relief for 4 to 6 weeks, improve function of shoulder mobility. So that's definitely key. Obviously, educating our patients and performing stretching. Those are going to be the main things to really look for, and maybe not focus too much on the modalities or joint mobilizations as much, since there's not enough evidence to support it. But obviously, you're going to make your clinical critical thinking of what you think is going to work best with your patient. So the next thing that we're going to kind of just look at here is going to be just joint hypomobility in general. And each patient's going to look totally different from one person to the next, but you're going to go through a process of management of the controlling the motion phase, where you're going to be controlling pain, their inflammation like edema, joint effusion, and increasing their joint and soft tissue mobility per patient tolerance. You're also going to be inhibiting muscle spasms and trying to improve or correct faulty mechanics, improve joint tracking, and improve muscle performance. Some from different things too, like when you're controlling pain, edema, and joint effusion, you want to take precaution that, if you, with increased pain or decreased motion with these techniques, that if the activity is too intense, then the patient may be using faulty mechanics, meaning that they're compensating, trying to make up for that motion. So you would need to modify maybe, to have a safer range of motion. So you would need to learn how to do that. And it's going to look different from one patient to the other. So with increasing joint and soft tissue mobility, maybe they would need passive joint mobilization techniques, especially for a grade 1s and 2s are for pain, grade 3 is for like stretching the joint capsules. So, but using a grade 1 distraction and gliding techniques that can help with the pain and improve with the tolerance. Let's see. When it comes to, let's see if there's anything else I really wanted to say about that. There's a lot of information that's mentioned in your textbook. Okay. So for the, with muscle spasms, that can lead to like a faulty deltoid rotator cuff mechanism, and can also alter their scapulohumeral rhythm, especially, so looking for that elevated, shoulder shrugs, because that's not going to be the correct way to do shoulder flexion. So avoiding those mechanisms if possible, and working maybe on some other techniques that we can talk about too during lab. All right, I'm going to move on to the next slide here. The next phase would be to return to function phase. So everybody's going to be at a different time frame for this. So it depends on a lot of things. This one, when we talk about hypomobility, it's very broad. There's several different factors that come into play, especially with age and mechanism of why they have hypomobility. So there's several different things, but obviously you're going to progressively increase flexibility and strength per tolerance of the patient. When it comes to the AC and SC joints, there's several pathologies associated, especially for overuse. So overuse syndromes, especially for the AC, might be because of stressful joint movements with the arm at waist level, such as like grinding, packing, assembly, construction work. If they have to do repeated diagonal extension, adduction, and internal rotation motions, or like even like spiking a ball for volleyball or serving in tennis. So the AC joint would be more susceptible to these overuse syndromes, and would be in conjunction with arthritis or following a traumatic injury. So for subluxation or dislocation of either the AC or SC joints, it's usually caused by falling on the shoulder or on the outstretched arm. And at the AC joint, the distal end of the clavicle often becomes displaced posteriorly and superiorly on the acromion, and then the ligaments supporting the AC can also rupture. After trauma and associated overstretching in the capsules and ligaments of either joint, hypermobility is usually permanent because there are almost no muscles that provide direct stability to these joints. So with hypomobility of the AC or SC, so if there's decreased clavicular mobility that may occur with SC joint because of osteoarthritis, this can contribute to thoracic outlet syndrome and compromising the space available for the neuromuscular bundle that is between the clavicle and first rib. So some common impairments in structural and function. So usually pain is localized to the involved joint or ligament. There's usually a painful arc toward the end range of shoulder elevation, so just where the shoulder is above the head. Pain with shoulder horizontal adduction or abduction. Hypermobility if trauma or overuse is involved. And hypomobility is sustained with posture, arthritis, or immobility is usually involved. So some common activity limitations and participation restrictions. There's usually limited ability with repeated forceful movements of the arm, especially for grinding, packing, assembling, or construction work. They usually have the inability to reach overhead or perform repetitive overhead activities without pain. So the next pathology we're going to talk about is rotator cuff tendonitis, and that is caused by the inability of a weak supraspinatus muscle to adequately keep the head of the humerus depressed into the glenoid fossa during the elevation of the arm. Participating in activities that require excessive overhead activities such as swimming, tennis, baseball, painting. Anything overhead will increase the risk of rotator cuff tendonitis. Patients may also experience a feeling of weakness and presence of a painful arc of motion, most commonly occurring between 60 to 100 and 120 degrees of active abduction. So what that means with that painful arc is, starting down below to do shoulder abduction, and maybe they have pain here, 60 to about 120 degrees pain, and then no pain again. Okay, so that's how they can present. And just to talk about a little bit more information, but the supraspinatus tendon is usually commonly involved with this rotator cuff tendonitis, and because the muscle originates on the supraspinatus fossa, the scapula, and it inserts into the greater tubercle of the humerus. So statistically, individuals from 25 to 40 years of age are the most likely to develop this condition, and individuals participating in activities with overhead will increase risk for rotator cuff tendonitis. And if you want to take this time to go and pause this video and look in your School Brothers textbook about rotator cuff tendonitis, we're going to go through a couple of things with that too. So like I said, usually with repetitive overhead activities, and the impingement will be at the supraspinatus tendon and immediately proximal to the greater tubercle of the humerus. Let's see if there's anything else I really wanted to say. Sometimes they can also have secondary impingement, and these are symptoms from poor mechanics or instability of the shoulder joint. Okay. All right, I already said about that. I already said about the painful arc. Okay, so the patient usually presents with pain and palpation of the musculotendinous junction of the involved muscle, which would be the supraspinatus usually, or with stretching or resistive contraction of the muscle. And pain often increases at night, and this will make it difficult to sleep on that affected side. They'll also have difficulty with dressing with repetitive shoulder motions, especially overhead. So for confirming the diagnosis, an MRI is usually used to identify, but however, it is high cost and to where, they might do the x-rays first, and with the shoulder laterally rotated can be used to identify if there's calcific deposits or other bony abnormalities. There's also special tests involved, like at the empty can test or the Jobe test, mere impingement test, or Hawkins-Kennedy impingement test that can be used to confirm the presence of rotator cuff tendonitis or impingement. Let's see if there's anything else. So besides the supraspinatus tendon for being with impingement, could also be the glenoid labrum, long head of the biceps, or subacromial bursa that's involved. Let's see. So with management, typically pharmacological intervention, such as like NSAIDs, cryotherapy, activity modification, range of motion, and rest. And in the acute phase, usually instructed in strengthening exercises. So since the rotator cuff muscles are dependent on adequate blood supply and oxygen, it's essential that all range of motion and strengthening exercises are pain-free. Range of motion exercises using a pulley system or cane could serve as an effective intervention, and strengthening exercises initiated with the arm at the side in order to prevent the possibility of impingement. Obviously, you can use elastic tubing, handheld weights, or what you choose, but it's important that the entire rotator cuff be stronger prior to initiating overhead activities. So like shoulder shrugs and push-ups with the arms abducted to 90 can be effective to strengthen the upper trap and serratus anterior. And this type of activity will promote elevation of the acromion without direct contact with the rotator cuff. So the outcome, so patients with rotator cuff tendonitis, they should be able to return to their previous level of functioning with conservative management within 4 to 6 weeks. And but it'll definitely depend on the stage of impingement syndrome. There's stage 1, 2, and 3. So stage 1 is usually found in a population less than 25 years of age, consists of localized inflammation, edema, minimal bleeding around the rotator cuff. Stage 2 represents progressive deterioration of the tissues surrounding the rotator cuff and is commonly seen in ages 25 to 40 years old of patients. Stage 3 represents the end stage and is usually found in patients over 40 years of age. So there's usually a disruption or a rupture of numerous soft tissues at that time. So long-term effects. So if a patient fails to actually get the rotator cuff tendonitis treated, then it's going to be more aggressive and might have to have surgery, and such as subacromial decompression. And prolonged inflammation of the rotator cuff tendon can also be to where they'll eventually have torn rotator cuff musculature. All right, I think so. Rehab, return to full function can take upwards up to 6 months. Heavy lifting may be restricted for 6 to 12 months following surgery if they're post-op procedure. Especially if it's for the rotator cuff. So you would look at the protocol for that too. And you can look over the scenarios that are involved with that. I don't think that there is one that I have seen, but definitely make for sure you look up and see if there's any CPGs related to it, and also on that rehab center for the APTA. So another common pathology is rotator cuff tear. So this is a result of an acute traumatic incident, more likely due to a chronic degenerative pathology, such as chronic supraspinatus tendonitis. The drop arm test and empty can test can help with identifying the supraspinatus pathology and could be indicated of a rotator cuff tear. So failure to adequately treat a rotator cuff tear may necessitate significant activity modification. They also might need to have surgical management. They could also see adhesive capsulitis or degenerative changes. Rotator cuff tears can occur due to acute injuries, but also chronic injuries. So chronic injuries are more common, and the incidence increases significantly with age due to extended use of poor biomechanics or muscular imbalances. With diminished circulation to the rotator cuff tendons and with aging, this can contribute to the increased risk of injury. There's always increased incidence in middle-aged males. And if you want to go ahead and look up rotator cuff tear in the Score Builders textbook as well. So like I said, I'm trying not to repeat anything, but tears can be classified as partial thickness, full thickness, acute, chronic, or degenerative. But the most common tear is usually involving the supraspinatus tendon. It just depends on the trauma and, because it could also damage infraspinatus and subscapularis as well, depending on the injury. But the rotator cuff, don't forget, is involving 4 different muscles: supraspinatus, infraspinatus, subscapularis, and teres minor. These muscles work together to provide stability of the glenohumeral joint, as we already know. Let's see. Okay, you can look over what each muscle does. We already know that too, but just review that. So how is it usually clinically presented? So they usually have pain and weakness is the most common complaint of a rotator cuff tear. They'll have generalized pain exacerbated with movements and functional tasks, especially in the lateral aspect of the shoulder, radiating down into the upper arm and deltoid region. Pain symptoms are likely to be more acute and specific with trauma, traumatic etiologies. And pain complaints are typically greatest with partial tearing, and this is because of the increased tension remaining on muscle fibers associated with neural tissue. If a patient has a small partial thickness tear, they may retain more functional abilities, while a patient with a large partial tear or full thickness tear will likely demonstrate significant functional deficits, especially with tasks involving with a shoulder lateral rotation and abduction. Other symptoms can include complaints of shoulder instability or stiffness, or that a lot of times you'll hear this too, of the glenohumeral joint grinding with mobility, or they have like that crepitus. It sounds like a Rice Krispie treats cracking and popping. Night pain and discomfort when lying on the affected side. Usually confirmed with an MRI and to help detect the location size and what kind of rotator cuff tear has been completed. But an X-ray is usually used to assess possible bone spurs within the joint capsule. So like I said, a drop arm test and empty can test can identify the supraspinatus pathology and see if it's indicative of a rotator cuff tear. Pain with resisted muscle testing is likely to be greatest with a partial thickness tear. All right. So management as well, just like with the other pathologies, usually pharmacological intervention. And, usually conservative management is best for chronic and older adults and before attempting a surgical intervention. So usually surgery without management can be indicated depending on, severity of symptoms, the size of the tear, and, usually they'll do surgical intervention will be arthroscopic, and may include also subacromial decompression, and they'll repair the tear of the tendon or both. So depending on the protocols, depending on how much of a tear that it is what you're going to go by with the protocols too. So patients who have undergone surgical repair, they're typically immobilized and in a sling for a period of time to protect the repaired tissue. So in the acute phase, you're going to be performing cryotherapy, activity modifications, range of motion, rest, and gentle isometric exercises. With progression, your focus is going to be restoration and mobility and joint mobes, range of motion, progressive strengthening exercises, and palliative modalities. Some other things is to promote scapular stability, posture reeducation, modification of functional work or recreational activities. So the outcome, physical therapy should begin immediately for conservatory management. Depending on the surgeon's preference, the patient may begin physical therapy immediately following surgical intervention or after a period of immobilization. So you'll definitely see that. A lot of physicians will do right after surgery, or they'll wait for a while and keep them immobilized in a sling. So it really just depends on the size of the tear, conservative versus surgical,
the persistence of symptoms, the patient age, the goals of the patient. You know, in cases where the tear is especially large or complicated, repair options are often limited, and patients may never fully recover with full shoulder function. So, if there's no issues, typically a patient can regain full function in 4 to 6 months. But however, with dynamic overhead activities, that's restricted for as long as 1 year. So if they are returning to sport, then it may be extended beyond a year. Some other things too, as well, is to where, long-term effects, if they didn't get the rotator cuff tear adequately fixed or modified, then they can result in adhesive capsulitis or degenerative changes. Since the tendon itself does not heal but rather forms scar tissue, there will be increased risk of rupture or increase in the size of the original tear. All right, and I think that is it about rotator cuff tear for this PowerPoint slide. For this next pathology, Hill-Sachs lesion is characterized by an impaction fracture of the posterior superior humeral head, is frequently diagnosed with patients who have repeatedly sustained anterior glenohumeral dislocations. And talking about the Bankart lesion as well, so is the name given to the avulsion of the labral ligamentous complex from the anterior inferior aspect of the glenoid, and the injury is commonly associated with anterior joint instability. With a glenohumeral dislocation anteriorly, this mechanism of injury can vary, but typically involves a forceful external blow or loading force when the shoulder is in the position that combines abduction, lateral rotation, and extension. So kind of like one of these. Okay. And prior to relocation of the joint, if there's a visible deformity, severe pain, and significant range of motion limitations are the most significant characteristics. It is not life-threatening, though recurrent dislocations can have a substantial impact on patients' lifestyle. But the vast majority of shoulder dislocations do occur in an anterior direction. With impingement syndrome, it's often caused by repetitive microtrauma from upper extremity activity performed above the horizontal plane. And patients that participate, especially in throwing activities, swimming, racquetball sports like tennis, are particularly susceptible. Long-term prevention includes continued strengthening of the rotator cuff and scapula stabilizers, along with improved biomechanics. So usually the, supraspinatus muscle is what is affected, where it attaches on the greater facet of the greater tubercle, placing it in close proximity of the acromion process. So the acromion process is the most often the structure that impinges the supraspinatus. So for shoulder instability, this is when there's increased space between the head of the humerus and the acromion process at rest, and it can indicate some form of instability present within the shoulder. So with this increased space between can result from a previous injury, and it will impact structures such as ligaments, capsule, muscles, bones that assist to support the shoulder. So a lot of times you'll see this separation, especially for someone that has had a stroke. You might see to where the shoulder looks, you can almost see the gap in between the humerus and the acromion for that shoulder instability. With bicipital tendonitis, this is the increased incidence of injury is associated with selected athletic activities such as baseball pitching, swimming, rowing, gymnastics, and tennis. And, they'll have characteristics or reports of deep ache directly in front or on top of the shoulder, which is made worse with overhead activities or lifting. And a positive speeds test or Yergesen test can show maybe that they do have bicipital tendonitis. So this one is also mentioned in your Score Builders textbook, so I do want you to look over this information. Um, let's see if there's anything else. Usually the inflammatory processes of the tendon of the long head of the bicep, and they'll have inflammation and pain, especially with repeated full abduction and lateral rotation of the humeral head can lead to irritation and inflammation and edema. Let's see. With the repetitive motion and overuse with these damaged cells within the tendon, they don't have time to heal, therefore leads to a tendonitis. So definitely with sports and work activities and repeated overhead with the upper extremity, like we already mentioned too. But years of shoulder wear and tear can cause the bicep tendon to become inflamed. And degeneration of the tendon, it causes a loss of normal collagen fibers that join together to form the tendon. So then you can have degeneration that can occur. Let's see if there's anything else. Some other reports I might say is it feels like a catching or slipping sensation of the biceps muscle. This can indicate a tear or a transverse humeral ligament tear. A bicipital tendinopathy, this is pain that's a palpation of the anterior shoulder in the area of the bicipital groove, where they'll have pain with biceps resistance test. And this would be a positive Yergeson or Speeds test. So there are no lab tests to really assist with the diagnosis of bicipital tendonitis. An x-ray does not diagnose it, but it can show calcification or subacromial spurring. An MRI can view the tendon, but it is expensive and not usually used when the patient is not unless the patient is not responding to conservative treatment. So obviously they might not have this exact diagnosis when they come into therapy because maybe they haven't had an MRI to actually show. So the primary goal for management is to relieve pain, reduce inflammation, regain full range of motion with rest or immobilization with a sprint or removable brace for a short period of time. The patient should avoid all overhead activities with reaching, lifting, or of objects. NSAIDs or other pharmacological interventions can be used. Let's see. Active physical therapy is not usually initiated immediately, but that, doing pendulum exercises, use of TENS, heat or cold therapy for relief of pain. Ionto or phonophoresis can be used. And then once they have progressed out of the acute phase and with physical therapy, they can work on stretches and strengthening of muscle groups. And this can regain and restore the tendon's ability to function properly with improved healing, prevent future injury. Surgical intervention is only recommended for patients that have not progressed with like therapy with 6 months a period of a time. But if they do have a surgical procedure, it's an arthroscopic decompression and acromioplasty with anterior acromiopnectomy. So the goal of therapy is to restore full available range of motion without pain. And once the patient does not experience pain or discomfort with activity, they may slowly return in their activities. But usually on an average of 6 to 8 weeks of physical therapy and rehabilitation. But obviously the prognosis depends on the patient, how long they've had the diagnoses for, and what their outcome is actually going to be, and what kind of activity they have to return to. So make sure you look over in the Kisner-Colby textbook about these intrinsic impingement, extrinsic impingement, and what they mean. Also, the different tendonitis and bursitis that are mentioned as well. And also, let's see if there's anything really different with that too. But usually with these, just showing that they can have posture and muscular imbalances, decrease thoracic range of motion, rotator cuff overuse and fatigue. So it's just in general for those. Make sure you look over, for controlling inflammation, promoting healing. So you're going to see a lot of repetitiveness when it comes to the management, especially like during the protection phase of, controlling inflammation, promoting healing, maintaining integrity, and controlling pain, develop support in those regions. So there's a lot of things that you can look over to show about those different for that phase and for the controlled motion phase as well of what is involved. Okay. And then there's also a return to function phase. So make sure you look over each one of those phases too. There's a lot of more of hypermobility, like with instability. There's trauma, hypermobility as well. This would be for like an anterior dislocation. Your textbook describes different phases, so look over what those would look like and differences between the two. Post-operative management. So for a total shoulder arthroplasty, there is, a total shoulder arthroplasty and a reverse total shoulder arthroplasty as well. They can even do just a hemi-arthroplasty where they only do like a partial. The reverse total shoulder arthroplasty is known as RTSA, and that is usually used when the rotator cuff integrity is definitely compromised. So make for sure that you look over the precautions with total shoulder arthroplasty. It's usually definitely in a protocol that will tell you, and we'll look over that information too. Um, a lot of times they might do shoulder arthroplasty because of arthritis, or if they have a humeral fracture, or where the rotator cuff is arthropathy, like where they, is not able to be repaired. So a candidate with a total shoulder arthroplasty, they will definitely exhibit impaired shoulder range of motion and strength, limited independence with ADLs, and severe pain. And the elective decision to have a TSA is most heavily influenced because of the presence of unremitting pain. Some other things too, they might have irreparable damage, deterioration, destruction of the humeral head and the glenoid fossa within the shoulder complex, a lot of times because either trauma or arthritis. Surgical complications include mechanical loosening of the prosthesis, instability, rotator cuff tear, implant failure, heterotropic ossification, and intraoperative fracture. So make sure you look up all what those look like. I mean, if you're not sure. Life expectancy is longer for the shoulder compared to the knee or hip since the shoulder is a non-weight bearing joint. So yeah, one of the common things too, loosening of the prosthesis or instability. I've seen people that had like subluxations or even dislocations before, so it's important to be aware of. Um, Reverse total shoulder arthroplasty is dysfunctional rotator cuff. A subacromial decompression, that's shoulder impingement that has not responded to conservative measurements. So it's usually, because of shoulder impingement. And the approach can be performed open, mini open, or arthroscopically, depending on the extent of the impingement and surgeon preference. Let's see. So there's different indications, like we just said, and maybe they weren't able to respond well with therapy with impingement, and then postoperatively they might be immobilized and in a sling after subacromial decompression, and usually the sling is at a position of slight abduction, internal rotation with the elbow flexed to 90 degrees. And it's usually worn for 1 to 2 weeks and then removed for exercise the day the day after surgery. Oh wait, 1 to 2 weeks, but it is removed for exercise the day after surgery. Yeah. So progression is going to depend on really how the rotator cuff impingement is in like the rotator cuff, like how it is and what kind, how the surgery went. There's maximum protection phases to where pain control, comfortable for 3 to 4 weeks, and prevent movement restrictions as soft tissue is healing, and attaining full or nearly full passive range of motion. The goal would be by 4 to 6 weeks postoperatively. Obviously, patient education and avoiding postures, and talking about exercises and ADLs that would be involved. So active unassisted shoulder range of motion is permissible as long as shoulder motions are pain-free and they have proper scapulothoracic and glenohumeral control. So this may be possible as early as 2 weeks post-op. So obviously at the beginning phases is controlled pain and inflammation using the sling when it's supposed to be implemented, cryotherapy, anti-inflammatory medications, relaxation exercises, and preventing loss of mobility, active range of motion, cervical, spine, elbow, wrist, and hand, postural control, postural training, and to restore pain-free shoulder mobility. So there's several different exercises that can be involved with that too. You can actually follow along with your textbook of what that progression would look like. There's a lot of information there. And also, you could even use a protocol that could be involved with that. So make for sure you look through that in great detail. I already kind of talked about rotator cuff and repair, but make for sure you look over that information in your textbook and the differences for procedures that are as mentioned on this PowerPoint slide, like a slap lesion. We really didn't get into too much today, but make for sure you look over those and for instabilities. So a capsular shift procedure is a chronic shoulder instability, and the procedure involves tightening of the joint capsule by cutting the capsule and overlapping the ends and to give it more stability. And it depends on what portion of the capsule needs to be tightened, will depend on the direction of instability. I already mentioned, I think, Bankart, didn't I? Yeah, it's a tear of the anterior shoulder labrum. Anterior capsular shift or Bankart repair, it's good to note that you're going to avoid external rotation, extension, and horizontal abduction until you're able to at a later point in time. It's pretty brief that's on there, but slap repair is tear of the superior shoulder labrum. So you want to avoid contracting or stretching the biceps. Posterior capsular shift, you're going to avoid internal rotation, flexion, and horizontal adduction. And here are some case studies as well, but we'll be talking about more of those in lab as well. So I know towards the end it was pretty short and sweet and to the point, but definitely make for sure that you look over all the additional pathologies that are mentioned in your textbook. Let's see. I didn't go in great detail, but there's some more information about glenohumeral dislocation anteriorly, so make sure you look over that information. And also that total shoulder arthroplasty, make sure you look over that. And the other pathology also would be the thoracic outlet syndrome. So like I said, make for sure that you look over CPGs. Also, the APTA Rehab Center is great. I know there's, and then also make for sure you're looking through that Brigham and Women's for their standards of care and their protocols. And that concludes our lecture over the shoulder today. Thank you. Have a great day.